All right, you know what time it is. We've only got 5 studies on the docket, and only 2 of them really are going to take any time to discuss. So, first up, association between vitamin D deficiency and residual dizziness in idiopathic BPPV, which stands for benign positional paroxysmal vertigo. Basically, it's one of the nice or happy forms of vertigo. One of the not scary ones. I think that's the best one. It's the not scary, one of the big not scary vertigos. And what they wanted to do is they wanted to see if post gold standard treatment, which is going to be a canalith repositioning maneuver, because the thought process is that with BPPV, you have these little otoliths, these little crystals in your ear that act as a buoy that essentially helps figure out between your eyes, your neck, and everything else where you're at in three-dimensional space. And that buoy sits in your inner ear that just helps figure things out, like, okay, my eyes are parallel to the horizon. My neck is telling me that my head is oriented more or less correctly. And then the input I'm getting from my ears, whether I am moving or standing still, comes from 2 different components. If I'm standing still, it's think of it, the body of the inner ear, the utricle and saccule. As soon as I start to turn, twist, like rotate my head to the left, or I start walking fast, it goes into the semicircular canals because I'm having some displacement there. So after that quick little review, what happens is after this canalith repositioning maneuver, which is oftentimes called Epley's repositioning maneuver, while it does work a majority of the time, you can get some residual dizziness for a while afterward. And while it's better, it's not more or less cured. So they wanted to see if it was maybe something like a vitamin D deficiency that can really peel out who's going to have this residual dizziness, as well as if it can be something addressed and fixed. And after going through the methods, basically it was almost 140 patients with different vitamin D levels were included, and they were stratified into normal vitamin D levels, insufficient, or deficient. And they also took note of their various risk factors for BPPV. They did a bunch of different functional tests to actually see how well that inner ear and the otoliths are functioning through various evoked myogenic potentials of the inner ear. So basically the right way. They did an old school thermal caloric testing. So just kind of thermally stress testing the ear to see how it responds. It's some new school and old school methodology, which is one of the ways that we can actually assess these things. So basically, that's what they did. They wanted to see the residual dizziness severity, so they measure that with a handicap inventory at 1 week post canalith repositioning maneuver, or Epley's. Now, what they did is they took that subgroup that they categorized as deficient or insufficient, and they received 12 weeks of vitamin D3 supplementation, and they wanted to see, all right, what was the result? Well, it's pretty cool, actually. Vitamin D did seem to help. So a moderate positive correlation emerged between serum vitamin D and disability scores. The abnormalities that were tracked were associated with residual dizziness. The degree of vitamin D deficiency that evoked potential and age emerged as significant predictors of residual dizziness. And there was significant increase in vitamin D levels before and after treatment in the treatment group, so it actually worked. Both groups showed significant shortening of the measured impulse wave latency after 3 months, so that they're improving and they shouldn't have residual dizziness, but only the treatment group showed significant reduction in a different parameter latency and their disability scores, which were reduced by 48.2%. Put another way, to sum up, the conclusion does it quite nicely. They confirmed in this study that vitamin D enhances otolith function and neural integrity, especially in those patients suffering with the residual dizziness with idiopathic benign paroxysmal positional vertigo. So if you come into my office and that's one of the things that we happen to be treating, maybe it'll be worth our shot to get a quick little blood test to figure out what your vitamin D level is at. And if you are lower than you should be, it's a cheap enough supplement and we can use it up here at Up North. So why don't we get you on it? Now, moving on. We have the relationship between rotator cuff disorders and abdominal muscles. What did they find? Well, they took people with rotator cuff injuries or disorders, and they wanted to compare that to their abdominal strength function. So they did it via an endurance test, as well as taking an ultrasound to the abdominal wall and physically measuring the cross-sectional area or thickness to see if there's any correlation between shoulder impairments, pain, and abdominal muscle strength deficiency. And yeah, that's actually not a surprise. That's exactly what they found. So 128 individuals, the strength of the abdominal muscles was evaluated by the endurance test was performed. It was also measured using ultrasound, like I just said. Shoulder-related pain symptoms and functionality were assessed with shoulder pain and disability indices. And what do they find? The rotator cuff group exhibited significantly lower abdominal muscle strength and endurance compared to healthy controls. A moderate negative correlation was observed between abdominal muscle performance and clinical scores. Then they basically just break it out as if it was right-sided, here's where they found the deficiencies, left-sided, etc. To me, this isn't of any surprise because your body's going to do what your body's going to do. If you're telling your body to do a task, whether it's an athletic event or a work-based event, and you have to use your shoulder, well, your whole body, but specifically your upper extremity, so shoulder, elbow, hand, etc., in some form or fashion, your body's going to do it to the best of its ability. And it's going through what's called a movement enneagram, where it's triaging resources to figure out what is the easiest way for me to get this task done. And so if you have a less than adequate, that's the wrong way I want to phrase this. If your body deems that your core isn't up to snuff to do the task, it'll probably recruit more movement, muscle activity, etc., from the shoulder itself. Basically, it's going to punt more of the job, more of the stress into the shoulder to do the task than your core, or than it wants to, because your core can't help out. If we use this as a real life analogy, rather than going with muscle strength, let's go with range of motion. Golfers. If you're going to line up and you're going to try and crack that ball on a drive as far as you can, you have to use your whole body. You have to be able to twist from your hips, your back, your shoulders, etc., to generate that torque to then bring it all the way around town and hit the ball. If your back is extra stiff or will not go as far as you want, but you're telling yourself that you got to hit that ball as far as you can, your body is then going to recruit more movement, more range of motion from the shoulders, and therefore more torque through the shoulders to do that job. So it's very often that when I'm dealing with a golfer with shoulder pain, that we evaluate the torso, because it's one of the big energy leaks that if we can recruit more movement from the torso, we oftentimes can resolve the shoulder pain, because to do the task that they want to do, ergo hit the golf ball, now they have more resources at hand. So I didn't need to tweak, juice up, or do anything fancy with the shoulder. I just needed to give the body more resources available to it to do that job via improving their torso range of motion. This study is essentially saying the same thing, but with a different metric and different parameter. So this one I am not surprised about at all, because the torso is a beautiful, beautiful thing when it comes to force transferring. So transferring force from the floor through the core, wherever I need it to go, whether it's throwing, working, etc. And if I don't have as much working capacity available to me at any given point in time, your body's going to recruit it from elsewhere, whether that's from the lower extremities, so you're going to torque your hips more to get faster, or your upper extremities, ergo your arms, and you're going to have to whip it or do something through the arms more aggressively than what your body may be happy with. That's all I'm going to say on that one, because I can tell I'm starting to get rambly. Now, is strength the main risk factor of overuse shoulder injuries? A cohort study of about 300 amateur overhead athletes. So what I like is they kind of just tell you right up front, this is a cohort study, level of evidence is only a 3, but they break it down. And they wanted to figure out is if the ratio between external rotation, so cocking your arm back as if to throw, and the actual motion of throwing, internal rotation, if that ratio for isometric strength was the most prevalent risk factor associated to overuse injuries. Give me one sec. I don't know why I fix this every single time, but it always does this for some reason. We're on this one. What's the most prevalent risk factor associated overuse shoulder injuries in both sexes? In this small one, I'll jump the gun. That's essentially what they found. So first, 300 athletes split between male and female from various overhead or upper extremity sports. And they wanted to look at isometric strength, range of motion, and control to see what kind of stood out to them. Now, I would have loved to have seen more parameters than just range of motion and control. See the last study, like what was their core like, what was everything else like take a bigger, fuller picture. But hey, it's a cohort study and you got to kind of trim the parameters that you're measuring to try and be as focused as possible. I get it. So what they found was that ratio between how strong their shoulder was in the cocking motion versus the firing motion was present in 264 and 229 out of the 296 athletes measured in both the dominant and non-dominant sides, respectively. When they normalized that isometric strength, it showed significant differences for the dominant and non-dominant internal rotation, so the firing motion. No differences were observed between dominant and non-dominant external rotation. The prevalence of that internal rotation deficit of that shoulder joint, called GERD, and total arc of motion differences was low, and no differences between sexes. So basically, there are no other parameters that they saw when they measured that would really explain why they may have pain outside of the strength deficit. Why is that important? Well, it's really one of those things where I wanted to kind of show you guys this is a study that would show that we need further information. Like, it's a good start, but there are lots of studies, and I mean a lot of studies, that will demonstrate that strength isn't causative of pain, like a lack thereof does not automatically lead to pain. But this one at least helps us to ask additional questions after this. So, okay, in athletic populations, they tried to normalize for a few of the common things, and the only thing that stood out was that difference in shoulder strength comparisons between internal and external rotation. So what to do? Well, for now, from this study, they should implement shoulder exercises to strengthen the external muscles to decrease the differences between that so that you kind of normalize that ratio. It's not a bad thought, actually. And when it comes to overuse injuries, it's probably more likely that the strength isn't causative, but it's correlative. What's the difference and why am I being nitpicky? Well, I'm being nitpicky for several reasons. One, this is going out to the great interwebs, and I want to always make sure that I am never misconstrued and that I'm just de facto saying things. So I'm always going to leave a little bit of nuance and uncertainty in my language. But the reason I'm saying it's correlative is because if we go back to me talking about that movement enneagram again and how your body will then just utilize resources at hand to figure out the easiest way to do a movement, if you repetitively do the same motion over and over and you are shunting resources to do that movement, which will then show up as increased strength, typically, in that motion, if you don't balance things out or at least give a little bit of attention to the other side, your body will then kind of, during the natural chaos of athletics, of life, when it needs to use a different movement pattern to stay safe and pain-free, it will think that it doesn't have the resources at hand because you never paid attention to really train other patterns into that motion. Now, listening to me, that was probably like, what? My brain, what? Okay. If we go do a workout and I'm only ever doing like bench press, dumbbell bench press, I'm only pushing. I am never doing a barbell row. I'm never doing a landmine row. I'm never actually using any of my muscles in my back to pull. I will only get so far. And yeah, my chest will beef up, but I'll hit a plateau where now, after I get to a certain weight, my body will need to recruit additional muscles to break through those plateaus to do what I want it to do. And in the pursuit of trying to push to that plateau without adding more resources to my bucket, I can't. I won't go any farther until I injure myself. And I think that's what's happening here, is that these athletes, because of the nature of their game and how the motion is done, yes, there's a technique to it. You have to do it a certain way or within a certain parameter of ways to be effective. I think that if we're ignoring the opposite side of the body, we are going to develop these overuse injuries, not because it's weak, but more or less because we've never paid attention to it, and that shows up as being weak. And I hope that makes sense. Okay. Like a guy benching 400 pounds is not going to be automatically weak in a row. Like he's going to be strong. But if all he does is train bench, yes, it will show up as a deficit similar to what we have here with overhead athletes. So I don't think it should just be weakness. I like the fact that they talk it as it about a ratio. I don't want to get stuck on saying, like my bench press guy, if we get his barbell back row to the same level, 400, 500, 600 pounds, that whatever issues he has will go away. No, like just train it a little bit and tell your body that you can have additional patterns and additional resources at hand to do your favored or preferred motion. And I think we would naturally see a tendency of less problems, less overuse problems, because we have more strategies available. So basically, if you stuck with me this far and are fine with the ramble, TLDR, in summary, they measure the ratio. I like the fact that it's a ratio. They can only really measure strength. I do think it's correlative. I don't think it's causative. But yeah, nuance is king. You're not going to really catch me saying anything else about it. And before my brain kind of goes kaput, let's move on to the last two studies. Effectiveness of moving cupping therapy on pain and functionality in rotator cuff injuries, a randomized controlled pilot study. So I like that it's randomized. They admit that it's a pilot study, just a proof of concept. Can it happen? And yeah, we utilize this moving cupping therapy quite a bit in the office for various reasons, both neurologically, mechanistically, physiologically, whatever ology you want to implement here. I'm not beholden to any particular one. If it's placebo, hey, I'll still take it. But what they found here was shoulder pain in a clinic, people receiving traditional physiotherapeutic care for it. And the only difference was they added the moving cupping therapy to one of the groups and really measured the difference between what happened between the traditional and the moving cupping therapy group. So randomized trial, pilot study, it was small, 30 women, 25 to 65, so a pretty wide age demographic, diagnosed with a rotator cuff injury, who applied to the Istanbul Medipol University of Physical Therapy and Rehab in 2019, and they were randomly divided into those two groups. The conventional physiotherapy was applied to both groups 5 days a week for 4 weeks, so full month, 20 visits. Additionally, the treatment group, this moving cupping therapy group, was treated for 10 minutes, 2 days a week, so 20 minutes a week total for 4 weeks. They measured pain on a numeric scale, range of motion, general functionality of the shoulder, and quality of life before and after treatment, and then they compared. And it was even surprising for me just how many differences really came about. There were significant differences in pain, range of motion, disability indices in both groups. They had abduction and external rotation range of motion. It was more effective in the moving cupping therapy group. Significant improvements were seen in all subscales into the control group. Significant improvements were also found in all parameters except role limitations due to non-mechanical issues. So if they had emotional problems, well-being, etc. Yeah, I don't think the cupping therapy was going to necessarily cure that. I don't want anybody to think that. Yeah, so pretty cool. That's something that we actively used, is showing proof of concept that it can be beneficial in a randomized controlled pilot study for those going through a rotator cuff injury. So we just had some clinical evidence that it worked, but now we're starting to show that it may actually have something to it, and maybe we can start asking questions on what's the mechanism or who made it help. Can we start stratifying, who's better to receive the therapy versus not? All questions for the future, but for now, just cool that we have something on the docket that shows that it helps. Lastly, and hopefully I don't get preachy with this one, I'll try and keep it short. The patient perception, and this study is all about the patient perception of exercises, has a significant impact on their prognosis. So let's go through the study and figure out what I mean. They asked questions about exercise to patients to see their responses from it, basically. So they are asked about chronic low back pain history, views of exercise for chronic low back pain, current exercise and behaviors through various interviews. Then participants watched the interviewer perform a deadlift, a Jefferson curl, which is like a deadlift, but with a lot more back bending, a lot more flexion, and the bird dog. And they were asked what they thought of each exercise, if it was beneficial and why, and then they analyzed the data. So it was small, I'll admit, but this is also something I see in clinical practice all day long. So the study was small. The actual potential extrapolation of this is probably everybody in receiving care anywhere. Study small, effect big, okay? They viewed all exercises as beneficial for health and pain relief, which I was surprised because, especially online, people really do seem to hate the Jefferson curl. But they perceived the efficacy varied between exercises. Core exercises were deemed crucial for chronic low back pain relief, and this was from the patient interview. So this wasn't any of the interviewers saying that you need core exercises. This was the interviewees saying, yep, core exercises are crucial for chronic low back pain relief, while spinal flexion, see Jefferson curl, and external load were often perceived as potentially injurious. Distrust towards healthcare practitioners also influenced exercise perceptions. So basically, who is giving them that advice, who is demonstrating the exercise and giving them a narrative as to why they were doing it. If they had a distrust towards who was telling them that information, it would greatly change how they perceive that exercise. No surprise there, especially for anybody interacting in any capacity online. So what does that really mean? It means that it's actually kind of funny. I just saw something very similar on Instagram saying pretty much the same thing. You could get somebody selling you absolute snake oil in any variety, whether it's with a, fake supplement, whether it's with a really goofy exercise, as long as the person stating what they're doing comes across as confident and it is then received on the person who wants to do the intervention, who has the condition, as good information or it'll help them, there's a good chance that it will. Put another way, absolute gurus selling you junk, if you're willing to buy it, can still get great results with patients, even though there's no actual rhyme or reason that they should be performing any better than anybody else. It's really down to the confidence and perception of the person receiving care. Put another way, you could also be the absolute best and most knowledgeable doc in the world, but if the patient is listening to you and doesn't A, believe what you're saying, B, just distrusts you, or C, is really, really tied down to doing a certain exercise, and you as the best clinician in the world don't modify your approach to take in that patient's perceptions of what they may feel their condition needs, you won't get that greater results no matter how good you are, because when we're working in this field, it is collaborative because you have to always, always, always take the patient's perspective in mind. It's also why I'm not dogmatic about what exercises I deem will benefit somebody. Like, oh, if you have this condition, you absolutely must do this, niche exercise and it's the only thing that'll cure your pain. No. Like it's really fun to have a ton of flexibility in my office to figure out who needs what, when, where, why, and how, as well as to figure out who has an experience of doing different things and what has helped and not helped, and building a plan customized to them. So like for me, I have my go-tos and things that I love, but if I also know that the patient is not on board with it, I know that even though I know it's worked with a ton of patients in the past, it's not going to work for that patient. Even though mechanically it really, really should, the patient won't have any sort of buy-in. They won't do it. They won't see the benefit, and they'll be, pardon my language, half-assed about it. it's not going to be the exercise for them, no matter how many other people it's worked for. On the other end, it's also my job, if they have an exercise that they deem works, to include that so long as it's not truly dangerous or ridiculous, to include it in their home exercise program. That maybe I just leave it at face value and the patient can do it in between stuff that I recommend because it's a way for them to get buy-in. Maybe I modify the patient's exercise that they think will help just to tweak it to do some of the things that I want, but still leaves it in their realm to view it as something that they're taking control of for their pain. This study, while it's short, while it's simple, it highlights a ton of things that can take a long time for any practitioner to really grasp as far as working with patients and not against them. And if you're too tied down in any sort of exercise, any sort of system that you cannot address the patient in front of you, it doesn't matter how good that system is, you aren't going to serve that person in front of you because they're not bought into the same system. So we really need to be flexible about our approach, understand principles of exercise, of rehab, of pain, over just memorizing protocols and things like that, because people are people, and you got to treat them as such. You can't put them in a box and expect the same result every single time. And that's a beautiful curse of the job, is that it's, no 2 days are the same. And sometimes it's frustrating, but other times it's beautiful, all for the same reason. And on that preachy little note, I'll end it there. Till next time.